talk tonight. This is a little bit more in-depth talk than we normally give for Fertility 101, which is kept on a very introductory, basic level. We're hoping to give you a little more information. This talk is designed for people who are more specifically interested in learning about IVF. So I'm Kristen Cain. I'm a reproductive endocrinologist, which means I'm a fertility doctor. I'm double board certified in OBGYN and reproductive endocrinology and infertility. I've been doing this for almost 30 years. And I've been in all kinds of different practice settings, from private practice to academics to hospital-based practice to Kindbody, which is its own thing. Kindbody is a new company. It's a startup, and our goal is to bring good access to fertility care to people all over the country. And so we work closely with each other. I work closely with doctors in Southern California and the Pacific Northwest and New York and Texas and Minnesota and Illinois, all over the place. We're all friends and we are partners with each other. And it's just this amazing company that is bringing good quality, kind fertility care to people all over the country. We want to revolutionize care by delivering a great patient experience, including innovation and great success rates. We have proprietary technology in our lab and in our patient portals, and we believe in access to care for anyone who wants to have a baby. So what do? This is it. We do a lot. If you're just trying to figure out what your fertility is like, if you want to know that, we do fertility assessments. If you need more in-depth fertility care and treatment, you've already been trying for a while, or you've been in other practices and not been successful, we do that. We do IUIs and in vitro. We do PGT, which is the genetic testing of embryos for genetic or chromosome problems. We freeze eggs and sperm and embryos to preserve fertility for future times. We have a strong motivation to take care of LGBTQI patients, and we want to be a supportive and comfortable environment for people who identify as such. We have KindMan for male reproductive health. We do genetic testing, and we even do at-home fertility tests for people who just want to dip their toe in and get a little bit of an idea. We offer counseling and support. We even have in-house third-party reproduction for fresh and frozen donor eggs, embryo donors, and gestational carrier surrogacy. And we focus on wellness like nutrition, yoga, at-home acupuncture, and mental health care, among other things. Our goal is to provide a holistic experience to treat your whole self and to help you develop and build the family that you want. We're on this journey with you. But although time heals all wounds, it's not so great when you're talking about your fertility. You know, time is one of our biggest things that we struggle with. And so we want to be time sensitive. We want to be able to give you good information so that you understand what role time plays in your own fertility and develop a welcoming and inclusive experience for all. So we have 3 things that we need to know about to help you figure out what's going on with your fertility: eggs, sperm, and uterus and tubes. So starting with the eggs, women are born with all the eggs they're ever going to have. It says here about 2 to 3 million, but often it's more like 1 to 2 million. And by the time you reach your first period, you're down to about 400,000 eggs. And at that point, you lose about 1,000 eggs per month. So if you think of the eggs, that you have in your ovaries like a gigantic football team, about every month, 1,000 of them get kicked off the team. They never even make it off the bench. Doesn't seem fair, does it? So to figure out egg health, we need to figure out where you are in this process, because by the time a woman goes through menopause, she's used up all of her eggs. So we need to assess what your ovarian reserve is. How many eggs do you have in your ovary? So we can do that with some blood work and an ultrasound. So the blood work, the most important test is this anti-Müllerian hormone, or AMH. And it reflects a general sense of egg quantity. So we like to see it between 1 and 5 or 1 and 6. Over 6 is high, less than 1 is low. We can also check FSH and estradiol hormones. These are usually checked at the beginning of a cycle to give us an idea of what that cycle's like. How are you going to respond to fertility treatments in that particular month? Those two hormones tend to fluctuate more cycle to cycle. Anti-Müllerian hormone fluctuates a little, but it tends to vary in a much narrower range. And then ultrasound, we do an ultrasound to count the number of follicles that we see that month. And this number says 6 to 8. Actually, a normal follicle count is 12 to 24. This is 6 to 8 per ovary. A normal follicle count is 12 to 24 at any given time for a woman under the age of 40. So let's talk about the follicle count a little bit. We do an ultrasound, and the ovaries look something like this, something like a chocolate chip cookie. And we can count the follicles up. So we can just go 1, 2, 3, 4, 5, and count how many are there. And like I said, we expect 6 to 12 follicles per month per side, or 12 to 24 total. And a good way to think about it is they're always coming to the surface. So if you think of a glass of champagne, the bubbles are continually rising to the surface. So if we were to look at the surface of the glass, we'd see, bubbles popping and continuing to rise into view. So this is counting those bubbles on the surface. But what it doesn't tell us is how full is your glass? When are you going to be out of champagne? That's what the AMH helps us tell. It doesn't really tell us when a woman's going to be out of eggs, but it does give us a sense of if the count is normal, overfilled, or low. And maybe if it's low, maybe we need to pay a little more attention to time. So what happens when an egg ovulates? The egg ovulates and it's picked up by the fallopian tube. And if there's sperm, at the same time, the sperm travels through the tube, meets the egg, and fertilizes the egg in the tube. And then the egg is filled with these little ciliated cells. So they're little cells with hair-like projections that sort of sweep the fertilized egg back into the uterus where it can implant. People hear a lot of talk about under 35, over 35, under 40, over 40. Why do we set these big cutoffs? What is all the fuss about age 35? Well, age 35 is typically the age at which we see fertility decline. If you look at, all people under the age of 35, couples where the woman's under 35 have about a 1 in 8 chance of experiencing infertility when they try to conceive. But at the age of 35, that goes to 1 in 3. And at the age of 40, it goes to 2 in 3. So although it's not a switch that just turns off, the eggs, since they've been there since birth, age with us. We run lower on eggs and we run lower on egg quality. And it's important to know that about 1 out of 10 women experience low ovarian reserve under the age of 35. So even if you're under 35, it's good to check your ovarian reserve. Egg quality declines with age as well. And the reason for that is if an egg is poor quality as it gets older, it's been there since birth, there's like this protein matrix inside the egg that divides up the chromosomes after the egg fertilizes. And that helps that helps the chromosomes sort themselves out. When that doesn't function normally, you wind up with an abnormal number of chromosomes in the fertilized egg, and that fertilized egg now either won't get you pregnant or cause a miscarriage. It will cause a miscarriage if it does get you pregnant, or that's where Down syndrome also comes from. So egg quality is impacted by age. It's not as easy to test for egg quality. Really, the best way to test for it is if you have a baby and then that was a good egg, or if you do in vitro, then you get a sense of what the eggs look like at every step of the way. Do they fertilize? Do they develop normally into an embryo? Does the embryo is the embryo have a normal number of chromosomes? And an abnormal number of chromosomes is what we call aneuploidy. So as women age, the weak eggs cause more abnormal embryos and less chance of babies. So the live birth rate drops and the number of aneuploid embryos increases. There are other things that can affect eggs too, but this is more the ovulation piece of things. So do the eggs actually ripen and ovulate? And these things are usually hormonal things like polycystic ovary syndrome or thyroid or prolactin hormone abnormalities. Prolactin is the milk hormone that causes your body to make milk when you're breastfeeding a baby. There's something called hypo, which is an underproduction of the brain hormones that stimulate the ovaries to ripen up and ovulate eggs. And then there's ovarian failure or menopause, where the ovary has actually started to run low on eggs. The second piece is the uterus and tubes. So to get pregnant easily without fertility problems, you need a healthy uterus and open fallopian tubes. So different things happen during the cycle. When the egg ripens up and it grows into a follicle that we can see on ultrasound, one of those follicles is selected by your brain hormones, your FSH and LH, to go the distance, to ripen all the way up to a point where this is about 1 inch in diameter before it ovulates, and then to ovulate the egg. And then those hormones do something else. They recycle this place where you ovulated from into something called a corpus luteum. This is a different kind of cyst in the ovary that we can actually see on ultrasound, and this makes estrogen and progesterone to support a pregnancy. If you're pregnant, the pregnancy makes HCG hormone that talks to the corpus luteum and gets it to continue making hormones, and the hormones support the pregnancy supports the corpus luteum until the pregnancy has grown big enough to make its own hormones, and then this dies off. These hormones do other things. So when you have your period, you're shedding the lining of the uterus because the hormones have dropped, and then as the follicle grows, makes estrogen that thickens up the lining of the uterus. And when you ovulate, the lining of the uterus starts to change. It becomes what we call secretory, and this is a more favorable place for a fertilized egg to implant. So we do ultrasound. One of the things we look at in ultrasound is we look at the lining of the uterus and we go compare that to where you are in your cycle to see if it is ripening appropriate to what your cycle should be, and if it's thickening in an appropriate way. Tubal problems can also cause infertility. If the tube is blocked, then the egg can't fertilize. If the tube is swollen and filled with fluid, sometimes this fluid can leak back into the ovary. So even if you did get pregnant on the other side or with IVF, that leaking fluid can be toxic to an embryo and keep you from having success. Things like endometriosis can cause tubal disease or scarring. Infection can cause it, or previous surgery can cause it as well. So if you have a history of painful periods, or a history of chlamydia or gonorrhea or other STDs, or a history of pelvic or abdominal infection like a ruptured appendix or a ruptured ovarian cyst, those are all things that could tip us off that maybe we need to look closely at the tube sooner rather than later. Endometriosis is a condition where the lining of the uterus sheds, to give you your period, but some of it backs up through the fallopian tubes. And most of the time that's no big deal. Your body just clears it and it's fine. But some women have an immune system that gets very freaked out by this process. It says, oh my God, I got to wall this off. And so what the immune system does is it creates scar tissue to try to wall off these little areas of uterine lining. So these areas just kind of implant, they're stuck where they are. And then as the hormones rise and fall during the menstrual cycle, these shrink and swell. It causes more scarring and more damage to both the ovary and the fallopian tubes, and also causes pain. So the test for the tubes is an X-ray dye test or a saline bubble study where we put bubbles through the fallopian tubes. Most of our Kindbody clinics, the bubble study is what we do for the first line of treatment or testing. We put water with little bubbles in the uterus and do a vaginal ultrasound. But sometimes, especially if we're really worried about scar tissue, we do an X-ray dye test at a radiology center. When we do an ultrasound to look at the uterus, this is what the uterus looks like. It's outlined here. And then this is the lining of the uterus. So before you ovulate, the lining of the uterus should be, up to 7 millimeters thick around the time of ovulation, maybe thicker. And we want to see 3 lines, 1, 2, 3. And this is called a trilaminar uterine lining. And then after ovulation, the lining of the uterus changes. It becomes all the same kind of light gray. And that's because progesterone now has changed the lining of the uterus to make it more sticky and more hospitable to an embryo. There are other things in the uterus we need to look at too. Fibroids are really common. Fibroids are muscular tumors, they're benign, that grow in the uterus, and they can be anything from the size of a pea to the size of a watermelon. They can be very variable. They can be right inside the cavity and very small, but if you try to implant an embryo in there, it's not going to implant. They can be very large on the outside of the cavity and not cause a problem at all. So fibroids, whether they're problematic or not, it depends on location and size together. Sometimes they need to be removed and many times they don't. Many times it's worse to take them out surgically than to just leave them alone. But we have to figure that out. We have to look at that carefully. So doing the saline bubble study is helpful for that. It can also show us if you have a fleshy growth inside the uterine cavity called a polyp. And like I said, if anything implants on here, it's not going to do as well as if it implants on a nice normal uterine cavity with a good muscular underbase. So sometimes surgery is required to remove these little polyps. If you do need this test, and a lot of people do, we recommend taking 800 milligrams of ibuprofen an hour before the test, and then we'll give you a little hot pack in the office to put on your tummy when we do the procedure. Hysteroscopy is another procedure that's sometimes done in the office, and that's a surgery where we place a small telescope about the size of a pencil into the opening of the uterus, and it allows us to look inside the uterine cavity and even shave off whatever we want to shave off to clean this up and make the cavity more normal. There are other uterine abnormalities as well. Some people might have a heart-shaped uterus, which is called a bicornuate uterus. This is a birth defect of the uterus that has 2 horns. Some people might have a septum. The septum is kind of like a heart-shaped uterus or bicornuate uterus, but this part's very fibrous, so it's hard for an embryo to implant in this. So usually we recommend surgery to remove the septum. We usually don't do surgery for bicornuate uterus, but we do monitor more closely for preterm delivery. And we want to avoid twins in patients with this type of setting. Or maybe you have Asherman syndrome, which is scar tissue inside the uterus, and that can happen from infection or previous pregnancy or surgery. The last thing is sperm. So sperm is tested with a semen analysis. It's a very simple and inexpensive test. And basically, the male partner just needs to collect a sperm sample into a cup, and then we look at it under the microscope. So we want to look at basically 3 things. We want to look at the count, which is also called the concentration. We want that number to be over 15 million. We look at the motility, how many of the sperm are moving. And we want about 40% or more of the sperm moving. And the last thing we look at is the shape or morphology. And we're happy if only 4% are normal. So as you can see from this picture, a lot of these guys are kind of funny looking. Most of them are not cute like this one. This is a cute, handsome sperm. He's got, a little cap of enzymes called an acrosome that'll help him eat through the wall of the egg. He's got the head that contains the DNA. So the sperm DNA can combine with the egg DNA to make a baby. He's got a neck that's got mitochondria in it, and that gives him the energy to swim, and a tail. These other guys are not as good looking, but it doesn't take a lot of really attractive sperm to fertilize the egg. If there are problems with any of those parameters, then we recommend an evaluation with a urologist. Kindbody has their own urology division called Kindman. Sometimes patients come to us who have their own urologist, and we work closely with them too. But whoever your urologist is, they may recommend other testing, like DNA fragmentation of the sperm, or testing for white blood cells or infection of the sperm. They may recommend fertility hormones, or genetic testing, or infectious disease testing. They might even recommend an ultrasound. It depends on what's going on and what the problems are, but we're here to help, and we're here to help with, it takes two to make a baby. Fertility is not just a woman's problem. And many of you who have already started the IVF process know this. They know how important the man's part of this is. It really is a 50-50 proposition, with a third of infertility being a problem from the woman, a third being a problem from the man, and a third being a problem with both. We want you to have a healthy baby, and we want you to have a good experience, and we want you to do this without any risk to your own health. So before we get started, we do require some female testing. We want your pap and physical exam, including breast exam, to be fully up to date. We'll check your other hormones, and we'll do infectious disease screening on you and your partner. Oops, we're not quite ready to switch yet. Go back here. We'll be talking about genetic screening, although that's not required. We do recommend it, and I do talk to all of my patients about that. And we check to see if you need vaccinations for rubella, measles, or chickenpox before you get pregnant. And if you are not immune, we do recommend updating those vaccines, as well as your COVID vaccine and your flu shot, because those can both cause serious problems in pregnancy. I want to say a little bit more about genetic carrier screening. So this is genetic testing on you and your partner, or if you're using a sperm donor, you and your sperm donor. But we need testing on both the man and the woman who will be creating the baby. The test we do tests for 502 genetic conditions, and carriers don't have the disease. They aren't sick. They don't have any symptoms. They might not even have a family history. But if a carrier of a disease tries to make a baby with another carrier of the same disease, you have a 1 in 4 chance of a baby with that disease. So a great example of this that a lot of people are familiar with is sickle. Sickle cell is really a terrible, painful disease. People with sickle disease really suffer from it. People in the family might have sickle trait, and maybe they have a little bit of a low blood count, but in general, they don't really have a lot of serious problems. And then there will be people in the family who are completely unaffected. I like to talk to people about this early in the process, because sometimes it changes the way that you do things. If you were to find out that you're both carriers of, say, Tay-Sachs, which is another terrible disease, it might change the way you decide to complete your family. Rather than risk a 1 in 4 chance of having a baby with this awful disease, you might decide to progress to in vitro sooner rather than later, so that you can get embryos and test them and identify the ones that have the disease and the ones that don't, so that you don't have to have a baby that is suffering from something that's terrible. If you find out you're a carrier of a disease, that's not a problem by itself. As I said, you could be a carrier of 10 diseases. Your partner could be a carrier of another 10, but if they don't match, we're not worried about that. And every time patients get a carrier disease screening in our clinic, they meet with the genetic counselor. Our patients in Atlanta meet with the genetic counselor at Semaphore, the company that does the test, and the counselor explains all of this to you in detail. It's a short 15-minute visit that goes through all your testing and gives you a chance to ask any questions you have. Other things that we want to consider for maximizing your health before IVF, one is BMI. So BMI stands for body mass index. And to have your BMI be as normal as possible before you do IVF is a good goal. If your BMI is over 30, it's not a bad idea to try to lose a few pounds. We don't really want you to go crazy and go on a super aggressive diet right before your IVF cycle, because that can also affect your eggs in a negative way, but a small amount of weight loss can have a big improvement in pregnancy outcomes. If your BMI is really low, like less than 18.5, we would normally recommend that you gain a little weight before you actually do your IVF cycle or your embryo transfer to maximize your odds of good health during pregnancy. Because Kindbody clinics are all outpatient, our anesthesia recommends that a BMI be less than 40 before we do an egg retrieval in our outpatient setting for safety purposes with anesthesia, because we don't put a tube in the patient's throat when they're asleep, and it just is important for managing the airway. So you might be advised, if you're in that higher range, that we need to have you take some weight off before we can do IVF in the clinic. It's not to be mean, it is purely a safety issue. Zika is another thing that, honestly, I kind of miss Zika. It's not such a big deal anymore, but with COVID, Zika seems like not as big a problem. But it's still out there. It's still in areas of the world. There's no vaccine available, and Zika does cause birth defects. Right now, there's no big areas of Zika outbreak. It is carried by mosquitoes. So if you're planning to travel, I would just recommend go to the cdc.gov website and look up. You can just type in the search bar Zika travel, and it'll bring up a world map, and you can click on the place that you want to look at and see if it's okay to travel there, if there's any worries about it. We want you to have a healthy lifestyle before you get pregnant. So that means if you smoke, you should stop. Even hookah and vaping are not good for your eggs or your sperm. Marijuana is one of those things that we don't have a lot of information on, but the little we have supports maybe stopping all that before you start trying to get pregnant as well. There is some evidence it may be harmful to eggs and sperm. There's really no evidence that it's helpful. We talked a little bit about weight and BMI already, and eating a healthy diet. Diets that are lots of plants, lots of vegetables and fruit are going to be your healthiest bet if you can get as many of your nutrients and calories from fruits and vegetables as possible. I'm not saying everybody needs to go vegan, but you want to aim for that, fruits and vegetables. Most of us don't get enough of those. And then minimize your processed foods. Kindbody also sells nutritional supplements like prenatal vitamins and men's health vitamins. We have CoQ10 and vitamin D3. This is all part of our goal to make things easy for you and one-stop shopping for the most important supplements that we recommend for people. And your Kindbody doctor might recommend other supplements in addition to that for PCOS or premature ovarian insufficiency or other problems. So before you do an IVF cycle, and you may have been, if you've had an appointment with us already, you may have already been through this exercise. It's important to think about what your goals are. So what is your goal? Do you want to get pregnant right away? Do you want to preserve your fertility? Do you just want to know what's going on and have the opportunity to think about things a little bit? And what's your long-term strategy for your dream family? How many children do you want? How old do you want to be when you have your first child? And how old do you want to be when you have your last child? How closely do you want them spaced? It's okay to dream a little bit on this. We'll do our best to satisfy that dream. And if there are things that are not possible for us to do, like get you 5 babies in 2 years, we'll talk to you about that and what your options are. It says here for women, age is an issue for their fertility, but age is also an issue for men. It's just that men do continue to produce sperm. The problem is more the sperm quality does decline with age. So age is important. And if you want to have your children after the age of 40, you're not ready to do that yet, and now you're 35, maybe egg freezing is something worth thinking about. I tell people your eggs are never going to be more or better than they are right now. And it's never going to cost less to get your eggs than it is right now. A study just came out in Fertility and Sterility, our big journal, that said the cost of freezing eggs when you're younger is a third to a half of what it is when you do it when you're older, over 40. So it really is advantageous to not wait. If you know you want this, then try to find a way to make it happen sooner rather than later. Doesn't mean you have to have a baby right away, but at least give yourself the option to have a baby right when you're ready for it. IUI and IVF may impact the ability to conceive later on. For me, the way I think about it is it's 2 years per baby, right? So if you get pregnant and you're pregnant now, that's about a year. And then you have the baby, right? And so it's about another year before your body's healed up from the birth and you kind of bounce back and your baby's not breastfeeding anymore if you're producing milk. And you're ready to start trying again. So on average, there's some variation in this, of course, but on average, it's usually about 2 years per baby that you have to factor in. So that's an important consideration as well. We talked about this already, so I'm going to kind of go past this slide. But one thing I do want to point out is we define true infertility as an inability to get pregnant after 1 year of trying, or if you're over 35, after 6 months of trying. But that does not mean that you can't start looking at what's going on with your fertility sooner than that. You can look if you're worried. You can look if you just want to know. You can look if you've had an STD in the past and are wondering if your tubes are open. You can look if you're feeling a little hot flashy and are wondering if you have enough eggs, or if your mom went through menopause at a young age and you're wondering if that's going to be a problem for you, or if you've been told you have fibroids, or if your partner's been in a relationship before and never got anybody pregnant. Those are all reasons to get checked sooner rather than later. If your cycles aren't regular, you don't have to wait for a year. You know that you're having problems because your cycles aren't regular. Your period is a vital sign. And if it's not regular, it's telling you something is off and we need to know what that is. Why is that happening? So at Kindbody, we don't put a limit on how soon you can check. I have people come in and want to start checking things out before, and they haven't even started trying yet. They're still on birth control. They just want to know what's going on. They want to know if they're going to have a problem down the road. They want to pre-plan. And I have other people who have been trying for quite a long time. And that makes me feel a little sad, I'll be honest, because I wonder what would have changed if I had been able to talk with them sooner. So that all leads up to the whole point of this talk. What is IVF? Well, remember that picture I showed you with the champagne glass and the chocolate chip cookie? Every month your body recruits a set of those eggs, that we call it a cohort, that group of follicles that we saw in that ovary ultrasound. And they grow and mature, and you ovulate one egg. But with IVF, we give you medication that helps all of the eggs in that cohort grow and mature. So we give you injectable medications for about 2 weeks, and we try to get a whole batch of eggs. A good rule of thumb is whatever your follicle count is, you can pretty much expect to get about half that number of mature eggs at an egg retrieval. So if you're told you have 20 follicles, we would expect to get about 10 mature eggs when we do an egg retrieval for IVF. So the injections work like this. You take these medications for about 10 to 14 days, and you have between 4 and 6 visits for ultrasounds and blood work. The ultrasounds are so we can see if the eggs are growing, and we can see when they're ready to go and how many you have. And the blood work is so we can make adjustments on the dose of your medication. We have a lot of videos whenever you're given your medication instructions. You will get links to the videos for how to do the instructions with the lovely Hina showing you how to do them. And I'm not going to make you watch a whole 9-minute video on Menopur, but you can find those videos online if you on our website if you want to check them out. Every Monday, this is important, we have a weekly Med Teach session. You can log on every Monday. It's interactive. You can talk to the teacher. If you need reminding, they send them out to us, those of us on social media, and we share those on Instagram or wherever. But you can just log on every Monday, 6 o'clock Eastern time, Atlanta time, 3 p.m. Pacific time. And if you've already, gotten a Med Teach, but you have a question about something, just go back on. It's free and it's there. So this is Dr. Garvin. She's my partner in Atlanta. We're partners in crime here. Once the eggs are ripe and they're ready to go, we actually give you something called a trigger shot. So the trigger shot is timed. It's given exactly 35 hours before we want to take the eggs out. And the reason for that is if we didn't give you that trigger shot, the eggs would stay very tightly attached to the wall of the follicle. And if we tried to aspirate the follicle, all we would get is fluid and no egg. If we give you the trigger shot and we wait too long, you'll ovulate those follicles and then the eggs are gone. So we have to time this just perfect. So for most of our patients, unless we've, decided that they need a little bit less time or a little bit longer, there's a few that are outside that 35-hour window, but most people it's 35 hours. So if we want to do an egg retrieval on Friday morning, we do the trigger shot on Wednesday night. So if the egg retrieval is 9 o'clock Friday morning, then 10 o'clock Wednesday night, you're going to do your trigger shot. And if you have any question at all, please call our nurse and ask about it. We would rather get a phone call late at night and answer an easy question than find out that you didn't know how to do your trigger shot and we're just guessing and then maybe something didn't go right. It's important to keep on top of your medications too and make sure you have all your medications. So when your medications first come, we do an unboxing of your medications with the pharmacy. And you will be continually asked to check your medications and double check you have everything that you need. So that if you don't, we can get you what you need and we don't have to, worry about 11 o'clock at night trying to find something to help you do your trigger, because that's not fun for you. The egg retrieval itself is about a 10 to 20 minute procedure. It's very quick. You have light anesthesia, so you're asleep enough you don't feel anything or remember anything, but you're not so deeply asleep that you can't move. that you can't breathe on your own. You just need a little nasal cannula oxygen. And then we place a skinny needle inside the vagina and the ovaries under ultrasound guidance, and we suction the eggs gently from the ovaries. An average egg retrieval, it's a 10 to 15 eggs, even 6 or 8 is a good number. Sometimes we get less, and sometimes we get a lot more. We get an idea from what we expect to get from your AMH and your follicle count. Sometimes you may not produce enough eggs to be worth going forward with IVF, and in that case, we might cancel if we don't think that we can do, if we think we can do better. Sometimes you have so many eggs and such a high estradiol level that it's not safe to proceed with IVF, but that situation's pretty rare. We stay on top of those things, pretty closely with the blood work and the ultrasounds. Once the eggs are out, they're in the lab. So this is an embryology lab with the embryologist here sitting at the microscope, and the REI doctor, Dr. Purdy, is watching the eggs be counted. So the eggs are counted and then they're fertilized with sperm. And the way we fertilize the eggs with sperm is with something called ICSI, where we inject the sperm directly into the egg. We expect about 70% of the eggs to fertilize, and then they're placed after we check the fertilization, which is the day after your retrieval. The embryos are placed in the incubator, and we pretty much just leave them alone and don't bother them too much until 5 to 7 days after the retrieval, when we start looking at them. Once they've reached to the size, that's called a blastocyst, which is a hollow ball of cells, then we can test them if we want to test them for genetic or chromosome problems. So how do we know if they're healthy? Well, we look at them under the microscope. This is a beautiful embryo. It's got nice, clean cells. It's a hollow ball, a blastocyst. It's got this clump here called the inner cell mass. So this part of the embryo is going to become placenta. This part's going to become the baby. We can also do PGT testing, pre-implantation genetic testing of the embryos. If we do PGTA, we're looking for aneuploidy, or abnormal number of chromosomes. That's what the A stands for. And what we do is we suction out a few cells, 3 or 4 cells from the part that's going to become placenta, and it doesn't hurt the embryo at all. The embryo can then be frozen while we wait for test results to come back, and these little cells are what goes to the testing lab. If we're checking for a specific condition like sickle or Tay-Sachs or cystic fibrosis, we need to make a probe to test for that condition, which can take a while. It can take several months to do that. But once we have that, then we can test the biopsy for that. Some people where time is not on their side, they have low egg count, we'll just make the embryos and freeze them, do the biopsy, and then once the probe is ready, we can do the test on the biopsy sample. Our goal is to have you have a healthy baby, to improve your odds of implantation and your odds of a live birth. PGT is approximately 90% accurate, but sometimes we don't get a result. Sometimes, in rare cases, the result is wrong. And sometimes we get something called a mosaic embryo, which is a little more difficult to talk about, because that means some of the cells are normal and some are abnormal, and it can be difficult to predict what direction the embryo is going to go in at that point. So those are things that we talk about in more detail if we're faced with those issues. So who do we recommend PGT for? I don't recommend it for everybody, but it's great. It's a great tool for a lot of people. If you've had 2 or more miscarriages, or you've had 2 or more IVF cycles and have not gotten pregnant, or a family history of genetic disease, or you're both carriers of genetic disease, or you're diagnosed with genetic disease, those are all good reasons to do PGT. I recommend PGT for couples where the woman's over 35 or the man is over 40, because those are situations where we see increased chromosomal problems. I don't typically recommend PGT for couples where the woman's under 35 and is trying for her first pregnancy or has never had a miscarriage or an abnormal pregnancy. Situations like that, PGT is typically only going to be recommended for couples who want it for gender selection, and we can certainly assist with that as well. So we do know the sex of the embryo, as I hinted at a minute ago. We might have a decreased chance of miscarriage and increased chance of success with people who are at higher risk of an abnormal number of chromosomes. But once you're pregnant, we'll do blood tests and ultrasound to see the growth of the baby before we send you to your OBGYN. So why wouldn't everybody do a PGT? Well, because you need to biopsy the embryo, and we're not 100% sure that every single embryo is going to stand up to that. Some embryos don't like being biopsied. It's an additional expense. PGT is not cheap, and the embryos do have to be frozen for PGT. So there's no option of a fresh embryo transfer. It's important when you go through the IVF process to have a good sense of what to expect. So typically, if we see 12 follicles at the time that we're ready to do the egg retrieval, maybe we'll have 10 mature eggs, and maybe 70% will fertilize, 70 to 80%. And I tell people, maybe about half of them will grow to the blastocyst stage. So now we're down to 2 to 4 embryos. And of those, anywhere from 0 to all 4 might be normal. And this kind of depends on the age. A normal embryo might grow to a full-term baby. The odds are pretty good that it will, but there's still about a 30% chance that that you transfer a normal embryo and you'll not have success. You'll either not get pregnant or have a miscarriage, and we'll need to transfer a second embryo in a second transfer cycle in order to get that live baby. There's attrition at every step of the way. It's not a perfect process. IVF is a numbers game. And the more eggs we have, the more mature eggs we have, the more fertilized eggs we have, the better off we are. Sometimes people need to do more than one IVF cycle to get enough embryos or enough eggs in order to have a good chance of success. And we can try to figure out that with you during the time of your consult. Embryo transfer is when we transfer the embryo back into the uterus. So it can be done fresh or frozen. Fresh embryo transfer used to be the name of the game back in the olden days when, I was doing this a long time ago. And at the time, it had a higher chance of success than frozen. Our freezing techniques weren't very good. And our fresh pregnancy rates kind of topped out at about 45% per attempt. Often we would transfer more than one embryo at that time because, again, our pregnancy rates weren't crazy high. And none of these embryos are able to be tested. With a frozen embryo transfer, the embryo can be tested and it's frozen, and it occurs 1 or more months after the retrieval. And something funny happened about 5 to 7 years ago when we got a new freezing technique that we all started using called vitrification. And this freezing technique was developed so that we could freeze eggs, which were really hard to freeze without damaging them. And so we were using vitrification for freezing embryos too. And all of a sudden, our frozen embryo transfer pregnancy rates were 70% and our fresh were still 45%. And we started realizing, hey, stuff goes on during an IVF cycle. You're taking all these medications and your hormones are all over the place and you're getting poked and prodded and you have anesthesia and you've got a lot of stress and maybe you're traveling and there's a lot. And maybe what's going on is not the best environment to get pregnant. Maybe the lining of the uterus is not doing everything it needs to do to get you pregnant. And so most of our embryo transfers now are frozen embryo transfers. It gives you time to recover after an egg retrieval. It reduces the risk of hyperstimulation of the ovary. It gives your ovaries a chance to recover. It gives us time to sync the timing of the embryo development and the uterine lining, which might be out of sync with a fresh cycle. It gives us time to do the PGT testing. And a frozen embryo transfer cycle is also worlds easier than an IVF cycle is for the egg retrieval. After you've been through an egg retrieval, an FET cycle is going to feel like just the easiest thing ever. It's one ultrasound to start estrogen pills. After 2 weeks, you have another ultrasound to start your progesterone, which can be either vaginal or a shot or both. And then on the 6th day of that combination, we do your embryo transfer, and it can be scheduled in advance with the doctor of your choice on a day that's good for your work schedule. You can get the time off. It's much nicer. So there's a real convenience aspect of an FET cycle as well. So this is what an FET calendar looks like. You know, you get your period. That's called day 1. We start the meds and do your ultrasound on day 2 or 3. You take your estrogen for about 2 weeks, and then we start the endometrion's a type of progesterone. You start that. We add, you know, this is doing estrogen and vaginal and progesterone and oil, and then we schedule the embryo transfer day. So if we know what day your period starts, we can plot this out and figure out what day we're going to do your embryo transfer. And then 9 days later, we do the pregnancy test. So it's no longer a 2-week wait. We've used up some of the 2-week with the progesterone part. So the way the transfer works is we do pass a very thin little plastic catheter inside the uterus with an abdominal ultrasound. So we want your bladder to be a little full. Sometimes people need Valium to help relax the uterus, but not everybody takes it. If you want acupuncture, you can do that either with the Kindbody acupuncturist or your own acupuncturist. You can do before and after your embryo transfer. Once your transfer is done, we want you to act like you're pregnant. In our office in Atlanta, the transfer room has a giant TV, so you can actually see the embryo be loaded into the catheter. You can see the dish that the embryo is in, see the embryo itself. You can see all of that. It totally demystifies the process. We do what's called a mock transfer before your embryo transfer cycle so that you can see what an embryo transfer feels like, and you don't have to worry or be nervous or anxious on that day. It can just be a beautiful, nice experience that you're getting pregnant. And then you can see the ultrasound. We do a little video clip and send that to you of the embryo actually going into the uterus. So it's a fun experience and a really good day. Pregnancy rates. These are general numbers from ASRM. They're not Kindbody specific numbers, but these are nationwide. But an average 35-year-old woman who does one IVF cycle has a 41% chance of having a baby. If she's done 2, it's 60%, and 3, it's 72%. So it's cumulative. I think, you know, our numbers are a little bit higher than this, but these are just good general guidelines. And compare this to IUI or timed intercourse, it's significantly better with IVF and even better with PGT. This is not stratified by age, so a 20-year-old is being lumped in with a 40-year-old in this setting, but it gives you a general sense. It's important to realize the path to parenthood isn't always linear. Sometimes we find roadblocks or wrong turns. We go down a road that we think is going to get us where we want to be, and it turns out that it wasn't the right direction to go in, and we need to back up and go a different way. We're here to support you every step of the way. We have therapists on staff at Kindbody. If you can go to Kindbody 360, you can talk to someone. We also have a Kindbody support group. And that's an amazing new thing. Excuse me 1 second. My phone is making noise because I forgot to silence it. So I apologize. We also do third-party reproduction. If, you know, not everyone has eggs and sperm and a uterus among the two people trying to make a baby, or maybe there's only one person trying to make a baby and needs some help. So we have donor sperm, donor egg, and donor embryo and gestational carrier options at Kindbody. We call it family building. Sperm donors can be agency, anonymous donors, or it can be a known donor that's selected by you. But all donors have to go through a screening process. Same with egg donors. They can be an identified or known donor, or an anonymous donor, and they can be fresh or frozen eggs. And embryo donors likewise can be non-identified or identified. For a carrier, you can carry the baby. You can have a surrogate, or if you're in a same-sex female relationship, you can do what's called reciprocal IVF, which allows both partners to have an intimate role in creating a baby. At the end of the day, there's no magic formula. Everybody's different. Everyone wants a different family for themselves. And the only way to make good decisions is to know what's going on, to empower yourself with knowledge, and to think clearly as you can about what the realities are of your own life. So the next step is just to learn. If you are already a patient at Kindbody, you've already started this process, but if not, we encourage you to make an appointment and talk to one of us about what you want to do with your next step. Kindbody has, I don't even know for sure how many signature clinics we have nowadays. I think it's over 20. There's more being built every couple of months. We have 4 in California, and Long Beach is being built. We have 1 in the Pacific Northwest, 1 in Minneapolis, several in Wisconsin and Illinois and Michigan. We have a couple in St. Louis, and we have 1 in Rogers, Arkansas. We have several in Texas. Ours, of course, is Atlanta. We're building a clinic in Miami. We're building a clinic in Charlotte. We have 1 in Washington, several in New York and New Jersey. We're building 1 in Philadelphia. We have a lot going on. Because you signed up for this webinar with your email, details are going to be in your inbox tomorrow, but we have a special promo. If you're a self-pay patient and you've never been seen at Kindbody, you can have a complimentary first consult. And anyone who books their IVF, any self-pay patient who books their IVF cycle before the end of the year gets 20% off their IVF treatment. If you have a benefit with Kindbody, be sure to activate your benefit and you can book it directly. You can schedule all of this at kindbody.com. So let's, do we have some questions from the chat? We have time for a few questions before we go find out what happened in the election. If anyone can stand to look.
Thank you, Dr. Cain. We do have a few questions in the chat. So the first question I see here is, what if there are a lot of follicles? Why is that bad?
Okay. Well, if you're doing in vitro, it's usually good. But sometimes women who have a lot of follicles, those follicles may have been hanging around for a while because they have PCOS and they haven't been cycling through them. So they just sit there. They're not ovulating them. They're not responding to the hormones and ripening and going there. They're like bubbles that didn't pop. And so some of those are a little aged and may not be as good quality eggs. The other issue with a lot of follicles that we worry about is something called hyperstimulation of the ovaries, where your ovaries, after we get the eggs out, can kind of fill up again with fluid, and you can have fluid in your belly or even around your lungs. So you have these fluid shifts in your body. It can be painful when that happens. And it can be a little difficult, a little hard on your kidneys. So we try to avoid that whenever we can. But that said, you know, you can get a lot of eggs from somebody and they don't necessarily hyperstimulate. And sometimes people hyperstimulate with only 10 or 12 eggs because they're just sensitive that way.
Thank you. And another question we have here is, before IVF and egg freezing, do you need to do COVID testing?
We do. We do COVID testing before you get your egg retrieval.
Awesome. And another question we have here is, if you have mature old eggs, is the only option an egg donor?
Not necessarily. If you still have eggs to work with, you know, once you go through menopause, there's no more eggs. The FSH level is high, the ultrasound, the ovaries are just quiet. There's no follicles in them. And no matter what we treat you with medication wise, it doesn't ripen up eggs. But if you still have eggs, then we can still try. They might not be as good quality. We might not get as many eggs, and you might have to do this more times to get enough eggs to get to some normal embryos. It's harder and it costs more, but it doesn't mean you have to do donor egg. It's a thing that you have to weigh. You know, you have to weigh time and cost and your desire for a child that's genetically related to yours versus a child that's biologically related to you because you gave birth to that child.
Thank you, Dr. Cain. And then this attendee also asked, if traveling, would we come to Atlanta the day before egg retrieval so we don't miss the timing?
Yes, if you live far away, it's your call, but Atlanta traffic is pretty terrible. So sometimes people do travel the night before just to have that be like a relaxing, easy day. And we do start egg retrievals fairly early in the day. Those are morning procedures.
Thank you. And someone asked, how long does PGT take?
It takes about 2 to 3 weeks to get the results back. So from the time that from the time that you have the egg retrieval to the embryo biopsy is about a week. And then it's another 2 to 3 weeks after that before we get the results back from once the embryo's biopsied.
And we also have another question here about genetic testing. Someone asked, if one patient is negative with genetic testing, does that mean the other patient, I think they're referring to the partner, does that mean the partner doesn't need to be genetically tested?
Yes, the short answer is yes. If you've had a full screen of 502 conditions, you're negative for every single one. That's not a common scenario. Most people are carriers of something. But yes, then you can waive the testing on your partner. But it takes about 3 weeks to get that genetic test back. And if you are a carrier of something and then your partner needs to be tested, now you're taking 6 weeks of delaying treatment while you wait to find out the answer. So what the company Semaphore does for our patients who are self-pay is they charge $250 per person for the test. That's the max out of pocket. You know, they'll bill your insurance for what they'll pay, but the maximum you'll be charged is $250. It might be less than that. But if you're charged that self-pay price and you do it as a couple where you both get tested at the same time to get it done in a timely manner, they do it at a discounted rate for couples. So you can save, I think, $150 just by doing it together and then getting your information faster.